Hello, my name is Ray Postuma, retired pediatric surgeon. Thank you for giving me the opportunity to present this work to you. Greetings from Winnipeg, Canada, where this work was done at the University of Manitoba. We're located in the middle of Canada and in the geographic center of North America. How do you diagnose appendicitis? This is a question our surgical resident circulated to 190 pediatric surgeons in Canada, Netherlands, and Saudi Arabia. 42% response rate, and this is published in the Open Access Journal of International Journal of Surgery. Surgeons were given the opportunity to select any or all of these parameters, and the number one choice was physical examination. The severity and location of a tenderness mostly. Next was the history. Next they chose imaging, mostly ultrasound, although in Saudi Arabia there was the CT scan was used more frequently. Observation and re-examination was chosen. Lab investigations, white count, C-reactive protein, and only one surgeon chose the appendicitis diagnostic score, which is interesting because there are over 900 papers in the literature talking about diagnostic scores. I'm going to take you on a completely different new journey, and that is of quantifying and measuring abdominal tenderness, something that's never been described before. I will show that this test is quick, it's simple, and a very sensible approach to assessing the acute abdomen and suspected appendicitis. Now, we're quite used to measuring things in patients, including those with appendicitis, and nurses will be very familiar with these numbers, vital signs and then some. However, when it comes to documenting abdominal tenderness, we use qualitative and descriptive items such as the location of the tenderness, the severity of mild, moderate, and severe, without actually defining what that means. And then the type of tenderness, and perhaps as a way of getting at the severity of tenderness, I'll just use rebound tenderness as an example. When a patient has rebound tenderness, they're generally thought to have severe tenderness. However, a rebound test is painful. So the question is, could we perhaps put numbers to abdominal tenderness? And one day when I was using a tire gauge to measure the pressure in my car tire, a light went on. Could we not develop an abdominal tire gauge to measure abdominal tenderness? And so the abdominal algometer was born some 35 years ago in our hospital machine shop. A very simple device, a spring gauge device, which when pressed on the abdomen shows a scale in kilograms, and then the patient is instructed to say ow or now, and when that point is reached, we have now reached the pressure pain threshold, measured in kilograms. As one child said, "My tummy hurts and my doctor thinks I'm a tire." The first things we did was to measure the thresholds in normal children, and these are 47 healthy children whose thresholds were about, on average, 3 kilogram per quadrant, slightly higher in the upper quadrant. The surgical residents will now demonstrate algometry. Left upper quadrant normal at 3. left lower quadrant 2.3, right upper only 1.5, and the right lower quadrant a mere 0.5 kilo. Now that procedure took exactly 30 seconds. At operation in this 12-year-old girl, we found a non-perforated retrocecal appendicitis. And her numbers, her abdominal numbers are shown here with an average of 1.8 kilogram per quadrant. The lowest was in the right lower quadrant, 0.5 kilo. The left upper quadrant was 3. So now we can actually describe numerically the localization of tenderness. And so we came up with the term of abdominal tenderness localizing ratio, ATLR, or abdominal ratio for short, 3/0.5 or 6. Later in our work, we decided on obtaining a non-abdominal global background pain threshold by measuring the forearm thresholds. Forearm thresholds, it turns out, readings are higher than the abdomen. So now we can actually come up with a global tenderness localizing ratio, comparing the forearm reading to the lowest threshold, in this case, ratio of 8. Now, if this girl had perforated appendicitis, very likely the right lower quadrant would have the same threshold, but the other quadrants would have a lower reading, say for example 1.5. So now the average reading would have gone down to 1.1 from 1.6. The abdominal ratio would have gone down to 3 from 6, but the global would be the same, 8. So how could we make use of all this information to help us in guiding us to the diagnosis of appendicitis? So we reported 2 months ago in Open Access Journal this study, a retrospective cohort study, and I'm grateful to my young colleagues for their contribution. First of all, a diagram showing all the lowest thresholds in 421 patients. 205 had non-appendicitis, 216 with appendicitis, and 66 of the lowest thresholds were in the right lower quadrant, perhaps not surprising. In fact, 89% of the lowest thresholds were below the umbilicus, 11% were above. However, now the difficulty begins. Based on our information, if you had a patient whose tenderness was most severe in the right lower quadrant, there is a 41% chance that this could be non-appendicitis, 59% appendicitis. Conversely, if the lowest thresholds were in the suprapubic region, there would be a 75% chance that this is appendicitis. And we found actually that most of these are pelvic appendicitis. So it gets to be confusing. So how can we sort this all out? First, the thresholds in just the right lower quadrant and the lowest quadrant. Now, by lowest quadrant, that could include the right lower quadrant, or it could include the left lower quadrant, for example, or the suprapubic region, or even in one case, the right flank. Remind ourselves that the normal is about 3. So the first column, clear column, is 205 patients whose threshold was 2/3 normal. Next is the non-perforated appendicitis, 139 patients, average just above 1. Next, the perforated appendicitis, 77 patients and the average just below 1. And then last column, all the appendicitis together, 1.1. And ditto for the lowest quadrants. The vertical numbers indicate the area under the curve, which we will describe a little bit later. Next, serial readings. We had 75 patients where we followed the thresholds, and 40 patients with, and 75 without appendicitis, 40 with appendicitis. Both groups started at about 1.5 kilo. However, over time, these the non-appendicitis, their thresholds rose to 2, while those who went on to develop appendicitis, their thresholds fell. So now we can use serial algometry to tell us which direction these patients are heading. Are they heading towards appendicitis or non-appendicitis? Next, global ratios. We don't have numbers, normal numbers, but we would predict that this will be about 1.3. So the higher the column, the greater the degree of localization. So you can see that in non-perforated appendicitis and in perforated appendicitis, the global ratios are highest by a 2 to 2.5 fold greater than non-appendicitis. Next, diagnostic power of tests. This is a standard way of looking at comparing diagnostic tests by looking at the area under the curve. The further to the left the curve, the greater the area under the curve, the higher the diagnostic test. We looked at 345 patients where we had white counts so that we could do a comparison. And the first was to look at just the white count, and the predictive power of just the white count, the area of the curve was 0.728, low. Next was we calculated, from our study, we calculated the 2 diagnostic scores, the Alvarado and the pediatric appendicitis scores. These 2 are the most common in the literature, and they provided the next higher level of diagnostic power. Above that were the thresholds, the lowest quadrant thresholds and the right lower quadrant thresholds. And then above that were the global thresholds, the forearm over the lowest and the forearm over the right lower quadrant, with the highest being 0.844, which is quite respectable. Looking at one subgroup, that is the males who had perforated appendicitis, their area under the curve is approaching unities, 0.935. So in males with perforated appendicitis, the algometry was almost perfect in predicting it. Next and lastly, this is coming to a climax now, where we can actually use the information to predict the probability of a positive predictive value of appendicitis and the negative predictive value. And I'm just showing the results for the validation group, which is half of the patients. And on the vertical axis is the predictive value, and on the horizontal axis are the thresholds. So as the ratio, a global ratio goes up, so does the predictive, positive predictive value. Conversely, as the ratio goes up, the negative predictive value falls. So this can be very useful in guiding us to the probable diagnosis. So here is, for the positive predictive value, is the linear regression curve, where X is the ratio that we found in our patient. So for example, if the ratio in our patient was 4, we would plug it into this formula, and our information indicates that the probability of of this patient having appendicitis is 80%. If the ratio is 7, then the probability of appendicitis is 98%. And if the ratio is 10 or higher, it would be 100% predicted of appendicitis. Here's a negative predictive linear regression. So, for example, if we had a ratio of 1 way on the left side of that horizontal scale, it would be negative predictive value for appendicitis of 91. 4 would give us 73, and 8 would give us only 49%. Our overall diagnostic accuracy in algometry was 79%. Our ultrasound was 79%. Very close, however, it's not totally comparable because not all the patients had an ultrasound. Also, the prevalence for appendicitis is lower in the ultrasound group, so that would give ultrasound a more favorable diagnostic accuracy. However, I have a spoiler alert. The overall clinical accuracy was almost 94%. In other words, the clinician, an experienced clinician, is still more accurate in diagnosing appendicitis than all the tests we have. Our conclusion: abdominal algometry quantifies the single most important examination parameter, that is the severity of tenderness and the degree of localization. It predicts which way this patient is heading. If you're observing the patient, it projects whether this is going to be an appendicitis patient or a non-appendicitis patient. It's most accurate in males with perforation. And if validated, this procedure has the potential to become a game changer in the assessment of suspected appendicitis. And it could be a very useful diagnostic guide. And I want to emphasize this. This is not a way to diagnose appendicitis. The only way you can diagnose appendicitis is under a microscope, taking the appendix out and seeing whether or not there's inflammation. But it could be a very useful diagnostic guide for less experienced clinicians. And it could also be a potential play an important role in virtual care, where we can see the patient, but we can't feel the patient, but we can see the numbers as they're produced for us. Alas, it's not as good as the diagnostic acuity or accuracy of an experienced clinician. I thank you for this opportunity.